Hello everyone, I'm Sang-Chul Lim. It's great to see you again in the monthly video review session. Today's topic is overcoming combined defect with the easy bone graft concept. As always, the surgery was performed by Dr. Zhang. And through today's procedure, you will be able to learn how to perform easy bone graft for large combined defect through proper material placement. Actually, finally, you can achieve a stable situation with immediate implantation. First, let's take a look at the previous session follow-up view. The previous session was here, about the lower anterior area implantation with bone grafting simultaneously procedure. That was osteon geno, and the collagen graft 1D was placed as used for grafting material on this lower anterior area. And the 42 and 33 was the target area to using bright TL. That was diameter 3.0 and 11 millimeter. So lower four anterior teeth is hopeless with mobility and root resorption and poor period condition. However, 33, the canine, it looks like intact. However, that was far from the lower, the ideal arch. So finally, Dr. Zhang have decided to extraction this lower left canine and then put the implantation simultaneously on the same side. Okay, that is previous operation. The pre-op intraoral view. As you can see, lower four anteriors are splinted with resin with wire splinted. And the poor periodontal condition and also root resorption was happened and the bone condition was poor. However, number 33 looks like intact compared to the previous lower four anteriors. Okay, that is pre-op CT view, number 42 area and 33 area. Very thin cortical bone plate was seen, and also the narrow ridge was seen, both of area. This one is post-op intraoral view, the already implant fixture inserted on number 44 and 33 area, and coupled with collagen graft underneath this material. Bone graft was inserted already, and suture. And after all of this procedure finished, and bright oral pack, to put this area cause of cover and protect this surgery area. Okay, this one is post-op panoramic view. As I mentioned before, 11 millimeter implant, the bright TL implant was placed on number 44 and 33 area. And another socket was filled with bone graft material and covered by collagen graft. And that is future site preparation. And also the socket preservation concept was applied for this procedure. And post-op CT is here, number 42. The actually lingual cortical plate was drilled. However, the changing the implant fixture axis. So finally, this implant fixture of bright T compact placement, and also this longer distal abutment can be used, a temporary abutment with a temporary PMMA. Okay, the provisional restoration was placed. And 3 months, 2 weeks after, we're going to take a final impression. So at this time, actually, you can see changing the distal abutment, the proper height. What about the ridge? Ridge was very nice healed situation, right? Very nice keratinized gingival zone and keratinized gingival band and the stable soft tissues and stable peri-implant tissues, and all the situation was completed and perfect for the final restoration. Okay, and scanning again, intraoral scan for the final prosthesis, as you can see. So all of these scanner image, the sending to CAD and CAD design for the final prosthesis looks like here. So we're going to make this final restoration using the articulator. Actually, all of these procedures on the CAD program and Dentium 3D viewer. And contouring and glazing, and the final process is here. The 4 months after surgery, finally, this final zirconia 5-unit bridge was installed, supported to implant bright TL, inserted to our patient mouth. Okay, so before surgery, as you can see, this number 33 canine was crossbite, have some occlusal problem. However, after treatment, this canine area have normal occlusion, looks like here. So I think the occlusal scheme is better before the surgery for the implantation after extraction on this 33 area. And the final prosthesis panoramic view looks like here. The 5-unit implant bridge was inserted on our patient mouth. And also pontic area, the filled with the bone graft material, actually stable situation looks like here. And soft tissues already healed, very nice situation, and there is no more problem, right? So I think this procedure, very simple and predictable, and the final process is also a stable situation combined with this distal abutment with bright TL. Okay, that is the previous surgery case, the final result. And let's move to this month's surgery. Today's surgery, the patient, 96 years old man, his chief complaint was this upper maxillary anterior areas in the uneven situation, right? So have some discrepancy between upper and lower, and have some curvature, and it is not aesthetic situation of old bridge. So he wanna make a new one with better aesthetic and normal the occlusal scheme. So he got the past dental history here about the implantation at number 25 area already. And the missing maxillary teeth from 14 to 21, the long span anterior area. Actually, this one is normally narrowed ridge due to long span bridge for a long time. So occasionally, normally this narrow ridge is very difficult to get the proper size and this proper diameter implantation on this site, as you know. So we need more strategic implantation and more strategic treatment plan. So what kind of strategic procedure and treatment plan? As follows. Pre-op view is here. And panoramic view, long span upper anterior area. As I mentioned before, the narrowed ridge. Let's see, number 13, 12, 11 area. Extremely thin ridges here, so it is impossible to get the proper diameter implantation for the proper location, right? So I think we need the GBR, big GBR procedure or the skip implantation on this area. Intraoral scan here, the preview scan. As you can see clearly, upper anterior, the occlusal scheme is good. I don't think so. Have the big discrepancy and have curvature and the non-aesthetic situation. So also patient need a little bit correction for this uncomfortable and unaesthetic situation. So finally, he have decided to have an implantation with the new processes. Okay, before the starting implantation or some another procedure, we need precise analysis. That is first a priority before starting some of treatment, right? So before starting the treatment, first the diagnosis, right? So for this proper diagnosis, shining 3D, the scanning view, plus the bright CT, the CT view, plus the facial scan, all of these features combined each other for the more accurate and precise analytic data. Very interesting, right? These procedures we can call the virtual setup. Each of the data merging and combined each other. So all of this situation was analyzed more precise before to make a procedure, before make a treatment plan. So facial data and iris data and CT data was stitched each other. All together data are stitching and gathering each other. So we're gonna handle all of this data. Looks like here, the virtual setup and some another procedures was done. Especially we can use all of these data on this 3D viewer from the Dentium CT viewer, right? So very simple and easy program. Just stitching each other and make a button, click the button, and we're gonna catch very useful information from this stitching procedure. So virtual setup. After virtual setup, we can see the lower anterior have some problem, right? So these areas also should be corrected for the proper occlusal the scheme. Before, after. So we are going to be this after treatment photos. That is our aim, our final goal. So for this purpose, we make some treatment procedures was decided. First, implantation on upper edentulous area. A bone grafting using osteogeno and osteogeno collagen, and the soft tissue grafting. This means enhancement of soft tissue, the joint, using the collagen graft. As you know, this one is best the choice for the augmentation of soft tissues. It's a collagen graft. And implantation will be on 14 and 21 tooth position with bright TL also. and diameter 3.0, 9 millimeter, and another side 3.5 diameter and 9 millimeter bright TL will be inserted. Okay, let's see the bright TL. This bright TL, as I mentioned before, external connection type, external taper connection type fixture that is unique and the different thing from another implant system. Actually, this one is external connection, right? So please keep in mind external connection with a 20-degree external taper. And the platform is single platform, 3.8 millimeter, and 1.5 millimeter soft tissue zone with concave design, and thread and dome-shaped body. That means a fatty belly style, so that is reduce the stress on the cortical bone plate, top portion. So that is very good for the eligible for this thin or weak, the marginal ridge type. So that is a perfect design for the narrow ridge. So if we choose this bright TL on the narrow ridge, they actually extremely minimize the bone graft situation. Okay? And what about osteon geno? That is geno bone graft from bovine cancellous bone. And osteon geno collagen, this one is collagenated bone, the source, the same as osteon geno and collagen binder holding this osteon geno particle. The 92% osteon geno bovine particle and 8% type 1 collagen from porcine origin. So many versatile butchers for the GBR and the contour augmentations, ridge augmentation, and socket preservation. This osteon geno collagen, a versatile graft material. Collagen graft is unique, the dense, the collagen matrix. So this one is actually to promote the faster the re-actylation. So especially in open wound site, this collagen graft initiate and activate this epithelialization, so faster healing procedure will be achieved. Okay, what is different between 1D, X1D, and X2D? This one is depend on collagen density. The collagen density is 2 times higher of 2D compared to X1D, right? So X1D, X2D, X3D is depend on collagen density. We can divide this kind of the categories. And the thickness is a little bit different. Thickness is 2 different types. First one is 2 millimeter and 3 millimeter. 2 millimeter have a yellow color code label. 3 millimeter, the green color code label, right? So 2D, 2 millimeter is thinner than 3 millimeter X1D, right? So X1D and X2D always depend on the collagen density. Please keep in mind also. Okay, let's move to today's surgery video. This long span old bridge was removed already, and after anesthesia, Dr. Zhang made a crystal incision with number 15 blade scalpel. For this crystal incision, as you know, the upper jaw case, especially upper anterior, upper posterior also, a little bit palatal, the inclined incision is better to flap management. For me, actually, from mid-crest, about the 2 millimeter, the palatally inclined, moving to palatal, and the deviation, the crestal incision, was made always. Okay, and after make of crestal incision, flap reflection was started using periostal flap, a periostal elevator. The palatal flap, generally speaking, as you know, the palatal flap is thicker than labial. So, if possible or if necessary, you can use this little bit thick, the palatal flap. If you want to have the connective tissue graft, you can harvest soft tissues from this palatal, the soft tissue zone. Now, using the round shape, the curette was used for the elevating the labial side flap retraction. So, what about this area? Number 21 site, actually very thin narrow bridge, right? So even though the top portion is looks like a little bit wider, however, just underneath this area is extremely narrow, right? So it looks like a little bit the mushroom style, the rich shape. So you have to always checking all the ridges shape. And this ridge shape already informed from CT view. However, after flap reflection, you have to check with instrument manually. And yeah, number 11, 12, 13 area also very narrow ridge here. So this area is impossible to have an implantation. Or another big, more surgeries like titanium meshes or some tenting screws for the GBR procedure to making enough space making. And there are many difficult procedures are necessary if you want to have an implantation or a bone grafting GBR procedure on this entry area. However, today Dr. Jung is showing us about the simple bone grafting on this narrow ridge, extremely narrow ridge with implantation, with the positioning implantation. So, very clever approach for this elder person. So, let's see. Okay, after flap reflection, now he made the crestal incision and the clavicular incision, and just reset the vertical incision here, and checking the proper position, and using high speed, a small round bar to make a position for the initial drilling on number 21 area. Okay, this area is 14 area actually. The long span situation, as I mentioned before. What to think about this high-speed bar usage? Sometimes we're going to use this style, the small round bar, to make an indentation. The narrow ridge case actually thick the cortical plate, the top portion. So instead of this procedure, just using the initial drill, like a Lindemann drill, even though the Lindemann drill first on this area, the top cortical plate makes some easier slippery during the drilling. So preventing this kind of discomfortness, Dr. Jung used high-speed bar first, and then Lindemann drill using for making proper the osteotomy with proper depths. I think almost 11 millimeters. Okay. The place of the parallel pin here, two parallel pin checking pass, and angulation and distance from neighbor teeth. The all of three-dimensional position was evaluated on this step, right? the final aim, the final purpose of the implantation is make a new implant-supported processes. Make a new implant-supported processes, right? So the position is important as well. Okay? Just the initial drilling, just only 2 drilling, right? And then the placement, diameter 3.5, undersized drilling was achieved, right? And until 3.0, final drill, and then go 3.5 diameter cause of this soft bone quality. Final drill here. This final drill have a Lindemann type. The final drill have a Lindemann style shape, so efficient to have osteotomy with the proper positioning, right? So nowadays, we have 3 different types of final drill kit available. 3.0, 9 millimeter, bright TL was inserted, this number 14 area. Okay, hand ratchet was applied to make more insertion of this fixture into the osteotomy site and get the proper depths. Good. Actually, at the bottom of this, the angle, the bevel portion, that is the same level of bone crest. Remove the plastic cap. This plastic cap, the working as a protector on the screw thread, right? And connect with the scan comfort cap. This scan comfort cap working as healing abutment first. Second, working as scanning jig. Third, working as a dual abutment-like function for the combined with the temporary prosthesis, PMMA temporary prosthesis. Can you see the notch? These notches for the scanning, right? Okay, all procedure was done. The essential procedure was done already. The very faster and simpler. The osteotomy from the osteotomy procedure and insertion procedure of the fixture. So all the procedures was done with a simpler way. Now, checking the pass and clearance. Okay, now 200 RPM with harvest drill. This harvest drill designed for the harvesting autogenous bone around the surgery area. So 200 without saline irrigation, just 200. The clockwise angle direction, and we can harvest this autogenous bone from neighbor area. Looks like here, the very simpler way and efficient way to take autogenous bone, right? So this autogenous bone was achieved once more using this harvest drill, 200 RPM without saline. All of this autogenous bone, promoting a brand new bone formation, as you know. So I think Dr. Zhang is at the xenograft, the top portion of this, the outer portion of autogenous bone area. Okay, so filled with osteon geno on the harvesting area. So osteon geno, as I mentioned before, as I informed you before, this bovine bone from the cancellous, bovine cancellous area. The source is bovine cancellous. So little bit faster the turnover rate. So the resorption time is faster than the bovine cortical. And it means the faster bone formation. The brand new bone formation was the faster made than the just cortical, the origin, another brand, the bone graft material. Nowadays, actually, I prefer to use this osteon geno when I want to use xenograft material. So what do you think about this absorption, the blood absorption rate? This osteon geno have lots of the pore. The large pore and micropore is well organized and well synchronized and harmonious. So the faster bone, faster blood absorption. So faster soaking. It is the essential properties of bone graft materials to make a new bone. Wow, very nice and perfect. The bone, the qualities, bone graft qualities. So the packing, a little bit dense, the packing around this implant fixture. The ordinary 2 millimeter of the bone from the outer surface of implant fixtures is a necessary part to make a long-term, the successful, the result. That is very general principle. So 2 millimeter bone is a necessary part from outer surface of implant fixture, especially on this anterior is important factor to maintaining well conditioned after insertion of implant fixture. So this autogenous bone first and the xenograft outer surface, and finally we're going to make the minimum 2 millimeter, the sustained on this area. Now, the interesting situation, normally, the previous procedures, the collagen membrane was applied for the GBR procedure to maintain space and to give us stability and the security. However, this time, Dr. Zhang is going to use collagen graft instead of collagen membrane. Why? This collagen graft is better, much better to have a soft tissue healing, right? So if you want to have a faster soft tissue healing, you may use this collagen graft. It's better. The collagen graft have the unique properties to initiate epithelialization and the connective tissue cell migration. So finally, we can see the faster soft tissue healing. And actually, as you know, this collagen graft have two different layers. Outer dense layer, inner coarse layer. The coarse layer is holding the blood clot and the blood cell and cell forming, the bone forming cells. And that is a good favor to make a new bone formation when I use this collagen graft. Okay. After that, he is going to have a suture, to make a suture knot here. This easy bone grafting concept composed with the bone graft material with collagen graft. But however, actually, let's see, this collagen graft is enough to have a function, the barrier function, compared to barrier membrane? Actually, that is question. First, resorption, the time. So normally, the barrier membrane have 4 to 6 months resorption time. So stay there on this GBR site during minimum 4 months. However, this collagen graft, the normal resorption time is 1 month. So 1 month is not enough to have a new bone formation, as you know. So, however, this easy bone graft concept is not the same as the regular GBR concept, right? So this easy bone concept is here. Let's see. First, all the implant fixtures, almost implant fixture surface surrounded by host bone already, right? For this purpose, actually, we have to choose the proper implant system, like like a bright TL system. The bright TL system, even though the posterior area 3.5 diameter is enough to have a prosthesis and strong enough, right? So reduce diameter. We can make a reduce the diameter on the proper positioning, with the proper positioning on the implantation site, right? So it is easier to have a host bone surrounding. Let's see, maybe 4.5 diameter, regular diameter on posterior, maybe the thread, easily exposed, right, and on the narrowed ridge, right? So on this kind of case, we have to decide it 2 different ways. First one, little bit deep insertion, or the bone grafting with the GBR procedure, right? However, let's see the changing the implant system, the smaller diameter, 3.5 bright TL, maybe 1 millimeter, the room will be maintained and manageable. So the bone grafting volume is extremely reduced, and also the initial stability is much higher, and all the procedures will be simpler, right? So that is easy bone graft concept. So first, implant fixation, the almost surfaces of implant fixtures surrounded by host bone first, and then the additional bone grafting with a peeling-free mind using collagenated bone and the collagen graft to promote the faster soft tissue healing. Okay, today Dr. Zhang showing us this is bone graft concept procedure on this anterior aesthetic area. Number 14 areas was the implant fixture for 3.0 diameter, 3.0 bright TL was used, right? And another opposite side, 21 areas, diameter 3.5, right? So the regularly, the normal system 3.0 is in case of internal connection fixture system case, actually 3.0 is extremely narrow diameter. So sometimes it is easy to broke, easy to sometimes some tendencies, the fixture, the crack and the break. So the risky situation. However, bright TL, the feeling free, the reduce all of this discomfortness and worry of surgeons. we don't have worry anymore. Okay. The interrupted sutures was done one by one. And now he made one more on this 21 area. Did you see what about the incision, the design, generally speaking, for the proper GBR procedure, as you know, this anterior area need big vertical, right? Maybe two big vertical incision was a necessary part to make a flap reflection and flap manage. And also the releasing incision to make some extension of flap. And the fixation method should be necessary part when we use the collagen membrane or some barrier membrane also. The membrane applied fixation procedure should be applied like suturing with the periosteum or pin fixation. It doesn't matter. Anyway, these procedures was skipped on this bone graft concept procedure using bright TL with the collagen graft. And no vertical, no releasing incision, no fixation, the tools, and feeling free, all of this complex procedure. And just only implant fixation and the bone grafting, the adding collagen graft, and suture. So, this the easy bone graft concept was strongly recommended for you. I also suggest to you this is bone graft concept, the bone grafting and implant insertion. Wow. So, yeah, so simple procedure, right? Okay, it was done. And thank you for watching. And we need a break time, 5-minute break time. And after that, we will have a Q&A session. Thank you. Okay, thank you for waiting. So now we are going to see the post-op intraoral view. After suture, we're going to see this very nice stable, the flap closure and also implant insertion situation. And the bright oral pack was applied, this surgical field. And the post-op panoramic view, number 14 and 21 area, the bright TL was inserted on this same side. And CT view, 14 area, 3.0 diameter, very nice, well done, inserted on the proper position and engaged cancellous bone. And the labial bone plate was enough. And also the bone graft matures was stable and stayed there with osteogenic collagen and collagen graft, right? And what about the 13 and 12, 11 area? Even though the extremely concave, narrow ridge areas filled with bone graft matures, osteogenic collagen, and also collagen graft mature. And I think these areas will be stable. And after this healing situation, healing period, when we have a prosthetic procedure timing point, actually these areas, volume of soft tissues will be stable. And the final lacerations looks like a very aesthetic, right? That is important part, even though this pontic area. And finally, 21 area, 3.5 diameter, a little bit thicker. However, the labial cortical bone plate are still there with the added bone graft materials. Yeah, okay, good. Okay, let's have a Q&A session. We have today we have two very good question was here. First one, why were both osteogenic and osteogenic collagen used in this case? The question is a little bit broad and unclear for me. However, I can understand osteogenic and osteogenic collagen combination, the technique. It means why did you use this combined combination technique? Actually, generally speaking, the particle bone is better than the collagen bone in the volume stability and the new bone formation. Why? Because of the collagenated bone have some collagen materials as a binder. So this collagen should be absorbed. And then the infiltrate between the bone particle areas. And finally, a newly forming bone was made. So this genocollagen have some little bit volume shrinkage compared to the particulated bone. So this particulated bone is more stable and the better situation to make a new bone formation, right? However, when inside of the handling the situation, the mean of the management and bone graft material, the particle bone is easy to scatter and it is very difficult to maintain the target area. So for this, for getting the stability of these bone graft materials, we need something more, like the membrane or the fixation procedures are necessary to make a stability of this particulated bone, right? So always bone grafting procedures, any way of GBR procedure, the stability is very most important thing to consider, important factor to consider, right? Stability is most important. So there's a stability case. Actually, this inside of stability, osteogenic collagen is better, right? The collagen binder is holding the particulated bone, and easy to handle, easy to manage, and easy to get the stability of the grafted material. So this underneath particle bone, the outside collagen bone, is a best combination of bone graft materials when you get easy bone graft procedure, right? And also this bovine bone, the xenograft, get the final result of new bone formation compared to some another alloplastic bone. So did you remember? Can you remember some of the harvest drill was used for the harvesting the autogenous bone, right? So exposed implant surface area, the autogenous bone is best choice. So take autogenous bone from the neighbor side and put the implant surface of the exposed implant surface, and then osteogeno, osteon collagen, that kind of procedures is best option. Okay, let's move to number 2. What was the reason for the placing collagen graft X1D and X2D at the different sites? Generally speaking, X1D is preferred. For me, actually, I prefer to use X1D on the ALP, socket preservation case. The cause of this X1D is a little bit easier to manage. The stiffness is moderate. So after soaking with the blood, very easy to handle and cover all these ridges, including the socket area, and easy to get cover all this exposed extraction area. So for me, collagen graft X1D preferred to used on the extraction socket side. And about X2D is more stiff due to the collagen density, right? As I mentioned before, X1D and X2D big differences is density of collagen density, right? So X2D case, they're using for the tunnel technique or some root coverage or the damming on the labial side and the buccal side, right? So in this case, Dr. Zheng is going to use X2D for the labial side damming, and X1D the covering the top portion of the exposed area, right? So when we have a suturing, X1D is better. Underneath of the prep is better to have make a knot with the primary closure and estimate the intimate, the prep closure. However, the labial bone, actually labial part damming or the buccal damming to the protect and holding the graft material, the X2D is better. So that is reason. That is why to use a different type of collagen graft was used on the different side. Okay, so that is my answer for your good question. Thank you for your good question. Okay, and today's monthly surgery video will be finished. And thank you for watching. If you missed any part of today's session or any previous episodes, available on demand replay on the clinical Dentium website. Okay, you can find on the Dentium the clinical website, so you can review today's surgery video. And okay, thank you for watching again. And let's see surgeon and periodontist in our Korea, in our country, Korea. Okay, thank you, and see you next time. Bye.